It's an honor to be here. I'm privileged to be in front of all of you. I'm a medical oncologist. The Aga Khan Hospital, it's not a university hospital, it's a hospital. Planned to start medical oncology or chemotherapy infusion program. January 2014, we started our chemotherapy infusion suite, and they hired me. So some of the issues we see in this part of the world is that 85% of increase in cancer burden is expected by 2030. Awareness, screening, preventive strategies are lacking. We also think that training and funding are lacking. The National Cancer Control Plan with funding is needed. 715,000 new cases in 2008, of which 542,000 died, meaning we have 75% mortality. Now, by 2020, we'd expect that 1.5 million cases are expected, from 715,000 to 1.5 million. So the burden is pretty high. Palliative care services are poor. The World Health Organization had 4 strategies: policies and procedures, education, drug availability, and implementation. They also then recommended a 5th pillar, research, because they think that that'll stimulate improvement of care. 80% are terminal at diagnosis. And 88% of cancer deaths occur with moderate to severe pains. So it's a terrible state here. 23 out of 52 countries have radiation therapy only, of which 20 countries have brachytherapy. Now, if you compare communicable diseases worldwide versus Africa, if you put communicable diseases, maternal, perinatal, and nutritional diseases, Africa has 68% of deaths, or 70%, almost 70%, as compared to 30% in the world. The non-communicable diseases is 25%, and cancer accounts for only 4 to 5%. So, in other words, the burden of healthcare is, if you and I are focusing on oncology, is very little in Africa. But as we tackle tuberculosis, as we tackle HIV disease, malaria, you'd expect that these would be more prominent and these numbers would go down. And now we can then focus on heart problems and cardiac problems and cancer. Look at the amount of money that is spent for healthcare in East Africa. The red bars are East African countries. We don't see Tanzania here. We don't see Kenya here. And that's because they probably have not reported. But as you compare that with the rest of the world, you see that the amount of money we have for healthcare in this part of the world is very little. And this we've seen previously is to see that the spectrum of diseases we see here are different from the West. Breast and cervix are more common. We see Kaposi sarcoma, we see liver cancers. In men, it's more so. We see Hodgkin's, non-Hodgkin's lymphoma, esophageal cancers we talked about, prostate cancer is very common in men, and this is the mortality here. So, 8 key cancer prevention and control challenges in the sub-Saharan Africa. Absence of cancer prevention and control policy. We have to write policies, strategies, programs. Insufficient data collection, heavy economical and psychosocial burden of cancer, so it's expensive, inadequate or no information about cancer, insufficient number of skilled the healthcare personnel is lacking here, high cost of immunization for HPV, unavailability of secondary prevention, unaffordability of treatment, so it's pretty expensive actually. Not only that, but also for palliative care. An absence of collaboration and coordination of interventions and stakeholders and donors to combat cancer. So if you and I come forward and say, well, look, we want to help you, you would realize that it's difficult. And this is a slide showing cancer awareness and knowledge about cervix cancer. It ranges all the way from 8% to 85% about the fact that there is something like cervix cancer, pap smears, what to look out for, HPV vaccination and all. About breast cancers also range from 8% all the way to 85%. This was a study on undergraduate students where the numbers are a little high here. Prostate cancer, also variable range of cancer awareness and knowledge. Testicular cancers, the fact that a lump in the testicle in a young man can be testicular cancers is also quite low. Notice that many of these studies are coming from Nigeria. 6 advocacies that are needed: political advocacy, educational advocacy, research advocacy, fundraising advocacy, support advocacy, community outreach advocacy. So going out in the community and working on cancer control. Radiating Hope is also an advocacy. So pathologists, how many pathologists do we have? If you look at Tanzania, where we have 43 million people, we have only 23 pathologists, meaning 1 pathologist for nearly 2 million people. And it's pretty grim, isn't it? But in countries like South Africa and Nigeria, we have more pathologists. So if you were to say, well, use tamoxifen, estrogen receptor positive disease, well, there is no place in the whole Tanzania where ER and PR are done. So what do we do with our specimens? We send it to Kenya. And then the turnaround time is longer. Leave aside, HER2 testing and so on and so forth, but we got to start with the basics first. When we develop pathology, we have systems need, we have quality assurance need, we have workforce need. Many of the cancers are advanced. There are taboos, and if a woman has had a lump in the breast, this is a rectal cancer and this is a breast cancer. There are certain tribes where having a lump in the breast or postmenopausal bleed is considered to be a curse. So the woman will hide and hide and hide till it's too late. And this is what then happens. So, it's pretty difficult here. Availability of cancer drugs is very little. Often available, these are the spectrum of drugs that we have, often available. Upon request, you can get these. And then rarely available, trastuzumab and rituximab, and so on and so forth. We have the lack of availability of these drugs. I had a case where I had a 17-year-old gentleman who had a nasopharyngeal carcinoma. It was an anaplastic nasopharyngeal carcinoma with both neck nodes involved, stage 4A. And I chose to treat him with induction chemotherapy followed by chemoradiation. And I didn't have the non-PVC giving sets, so I couldn't use taxanes, but I had cisplatin and I had gemcitabine, so I gave it to him. And then I put him on the list for radiation therapy. Of course, there is a time frame or lag behind of about a couple months or so. And I had a whopping 80% shrinkage of his disease, both his neck as well as the nasopharynx. And then I held the day 8, cycle 3 of gemcitabine in preparation for us to proceed with the radiation. Now he's getting chemoradiation as per the LSRAF protocol. So you have to modify your approach here in what is available and what you feel comfortable doing. This is a radiotherapist working at Ghana. So we've seen this slide. There are 2 places in Tanzania that have radiation therapy. One is Dar es Salaam and one I think is Mwanza. I think we're hearing the next talk coming up. I think that this place has the machine functional. We're lucky in that we have, but there are places in East Africa there are places in Africa that don't have any radiation therapy. Look. And there are places where there's only one radiation therapy. But then there are places where they have more radiation therapy. So we get patients from Mozambique and Madagascar coming over to Tanzania for radiotherapy and other things as well. And we've seen the slide before. In Tanzania, we have 3 machines, but we need 30. So we need another 27 machines. And this is about the other parts of the world, other parts of Africa as well. So we lack 27 machines for radiation therapy. This is home-based. This pink solution is oral morphine. This is home-based hospice. Uganda actually has done pretty well. These 2 workers are at home giving end-of-life care. But morphine isn't available in the entire Africa, many places in Africa. This white area doesn't have any morphine. Tanzania has oral morphine, and the green have morphine plus another narcotic. So we're lucky that we have morphine in Tanzania. We, in our center, do have morphine available, happily. But there are barriers to availability of opioids. It's sub-Saharan Africa, political barriers, clinical barriers, facilities, outreach centers, fear of using opioids, poor training, policies, and so on and so forth. Skilled personnels in assessing the pain and modifying it as need be. This is roadside hospice, something we've never seen ever before, have we? This is in Uganda. These ladies are officially offering end-of-life care outside a cancer center. So this is lovely. And this is home-based training about what needs to be done and what not needs to be done. It's a jeep with hospice. It's in South Africa. Countries that have operational policies, there are few. Tanzania is not a part of that. Gavi Alliance will make the HPV vaccine for only $4.5, and Tanzania is a beneficiary of that, even though nationwide introduction is planned by Rwanda, Mozambique, and Zimbabwe. Now, mind you, Mozambique doesn't have any radiation therapy center, but they're looking at HPV vaccine, which is good. By 2020, 30 million girls in 40 countries would have been immunized. Gavi partners with all the others, and you know about that. So it's changing the balance between industrialized countries and developing countries. It's a safe vaccine, as you all know. In the US, it's worth $100. They're making it $4.5 per vaccine here, and we talked about this. China and India are taking very good advantage of Gavi. We need that here more so. This is my center. I'm blessed with 2 wonderful nurses. They are Tanzanians, and they went to Aga Khan University Hospital in Nairobi for 4 months for hands-on training. They have concluded and passed the online chemotherapy and biotherapy certification course offered by Oncology Nurses Society, which is now offered online as of 2014, recently. A very talented young pharmacist, and this is the infusion going on at my place. Thank you.